Hello everyone, welcome to the session on learning AETCOM Competency 2.6. That is a case study, bioethics, autonomy and decision making. The presentation has my own views. The medical decisions should be taken in view of existing socio-cultural, regulatory and legal norms in the best interest of patient, respecting principles of bio. Now, the case study has the objective of identify, discuss, and defend medico-legal, socio-cultural, and ethical issues as they pertain to refusal of the care, including do not resuscitate and withdrawal of life support uh, orders. Now, the background is important. The Article 21 of the Constitution of India guarantees right to live, but it does not imply a right to die. So perspective for details. Now the salient points of the case in this AETCOM number 2.6 are: a 78 years old widow had a badly healed hip fracture and controlled hypertension on drugs. Once she narrated that he was traumatized by intubation and cardiac resuscitation done at the time of death of her sister with metastatic carcinoma breast. She conveyed to family doctor that she does not want such measures should be taken if she falls sick, and she insisted so on subsequent visits also. She has not involved any other member of the family, including son. One day she developed hypoxia and hyponatremia due to pneumonia and became drowsy. Intubation had to be done. She points out at the endotracheal tube at the time of intubation and makes a pleading gesture to remove it. His son came from foreign country and attended to her, wanted every effort to be done to save. The points of discussion are extent of patient autonomy, elements in decision making, competency versus capacity, surrogacy in decision making, autonomy versus beneficence, and how much does family wishes count, and legal, ethical, and social aspects of do not. I will discuss each one. The Mill's view of autonomy: a person is autonomous to the extent that he directs his action in accordance with his own values, desires, and inclinations. Autonomy is limited because of one's cultural and traditional beliefs are different. Incompetence and incapacity limits the autonomy. Evaluation of decision-making capacity should be involved in every patient encounter. The depth of capacity evaluation may vary from case to case and depending on the acuity of the illness, the patient's age and functional status, the patient's and family goals of care, the clinical environment, and socio-cultural and personal. Now, second point is competency versus capacity. Competency and capacity are two different terms often used interchangeably. Competency or competence is a legal term referring to individuals having sufficient ability, say, to make a will. In simple words, competency refers to a mental ability and cognitive capabilities required to execute a legally recognized act rationally. To disprove an individual's competence requires a hearing and presentation of the evidence in the court of law, and such an incompetence will be called as de jure incompetence. Competent adult patients have legal right to accept or refuse medical treatment. Therefore, patient must be competent at the time of making such decisions. Patients in persistent vegetative states, severely demented, severely mentally retarded, or actively psychotic would be considered incompetent generally as incapable of any rational decision. Capacity is the individual's ability, which is specific in nature, to understand and appreciate information to make rational decisions. A patient can lack capacity in one area but still have capacity in another. For example, a patient may be able to identify a close relative whom he/she trusts to serve as representative, but does not have capacity to consent to a complex medical procedure. Such individuals cannot exercise the right to choose or refuse treatment, and they require another individual, what we say is de facto surrogate, to make decisions on patient's behalf. Incapacitance may be temporary. For example, an alcoholic inebriated toxic patient. Doctor decides the capacity. That is important, and this is called as de facto incompetence by using methods for assessment. Many doctors request psychiatric evaluation to assess the capacity to make treatment decision under these. For the medical practice, decisional capacity is important. One is capable of understanding relevant information and appreciating reasonably foreseeable consequences when making a decision such as consent to treatment or do not resuscitate. A physician or psychologist evaluates an individual for capacity using either subjective opinion based on expertise or objective evidence based. Formal evaluations are used, such as cognitive function testing, general impressions of capacity, and specific capacity. Now, mental status examination is a must to assess capacity in all cases. Appearance, motor activity, speech, mood, affect, thought process, thought content, perceptual disorder, sensorium, cognition, insight, present or absent, and judgment, patient's ability to. Now, a patient proves his or her capacity by demonstrating an understanding of the information relevant to decision making by this testing, and number two, ability to weigh risks and benefits and to compare benefits and risks of the alternative options available. And third, communicate clearly with doctor about the decision in question and utter final decision. And finally, patient should show consistency of logic and decision making process throughout the. Now, so competency and capacity are different. Competency is determined by law, de jure incompetence, whereas capacity is determined by doctor. So it is de facto incompetence. Competency is categorical, whereas capacity is relative to the baseline abilities. Now, competency depends on individual's overall ability to understand and reason. Capacity is specific to a particular decision. Incompetence is a legal term that refers to an enduring, longer general inability to make valid decisions. In healthcare, medical decision-making capacity refers to an individual's ability to understand the significant benefits, risks, and alternatives to propose healthcare and make and communicate a healthcare decision. So what to do when a patient is assessed and found lacking capacity? If patient has left advance directive, that is called as explicit written directives, then doctor and health institutes act accordingly. But when advance directives are not available, then invoke implied consent in emergency, because emergency doctor will take its own decision. In non-emergency cases, surrogate decision maker, if it is available, then he will decide on behalf of patient. Even during emergency, a second opinion can be taken from senior physician, or a psychiatric opinion can be taken, or when there are difficult decision situations, then clinical ethics committee can be referred for making decision in the best interest of patient. Such actions depend on prevailing codes, regulations, social norms, and the third point to discuss is substitute or surrogate decision making. Substitute decision making is a mean of making decisions about health care on behalf of patients who are incapable. The substitute decision maker should be the person or persons with the best knowledge of the patient's specific wishes or the patient's values and beliefs as they pertain to the present situation. The task of substitute decision maker is to utter how the patient would want to be treated, and for that he requires reasonable and full health related information about patient so that a decision is made. Substitute decision making is an important part of healthcare policies of healthcare institutions and professional organizations, and this also follows principles of bioethics including autonomy. Surrogate decision maker may have conflict of interest. For example, he may gain from the death of the patient. Therefore, some decisions may be biased. The most appropriate person to act as substitute decision maker is the one appointed by patient while he or she was still capable. However, their order of ranking include patient's spouse, partner, child, parent, sibling, or other relative who know patient closely. When none exists, then court-appointed guardian is sought, and that will be called as de jure surrogate for making decisions. I'll talk something about autonomy versus beneficence. Autonomy is an important bioethic principle that entitles patients to decide, agree or disagree for a medical intervention. Patients have the right to make decisions that doctors don't even agree with and that are believed to be poor decisions by doctors, so long as the patient demonstrates the elements of decision-making capacity. That is very important. For example, a religious person may refuse intravenous administration of drug or blood transfusion even when informed that such decision may put his life at risk. This refusal may go against the principle of beneficence. So there is always some differences between autonomy versus beneficence, but respect for patient's autonomy takes precedence over beneficence sometimes. Not consenting for surgery in acute appendicitis, only medical treatment must be given. At least some beneficence is there. Socio-cultural factors also jeopardize autonomy. Personal choice is subjugated to family wishes in Eastern countries, thus affect. Now, a corollary to this subject is advanced care planning. In many developed countries, advanced care planning is a process whereby a patient, in consultation with healthcare providers, family members, and others, maybe a counsel or lawyer, makes decisions about his or her future health care if she or he meets with accident, becomes unconscious, or trauma. Two types of the advanced care planning is done: a living will, everybody knows, and power of attorney for health care. It is a legal instrument in some countries with limited legal status in India. It includes who will take health care decisions on her behalf or on his behalf, and what intervention the patient would or would not like in various situations, including no tube use or do not resuscitate. It is in the form of a written advance directive that is invoked to make healthcare decisions in future when patient becomes incapable to consent. Clinical care is thus shaped according to the patient preferences. How much does family wishes count? When patient has left advance care directive and assigned a family member to take healthcare decision, they should be invoked at the time of need. Studies have indicated that in traditional societies, family members commonly act on the behalf of the patient and often will make decisions such as not to disclose diagnosis or prognosis to the patient or not to intubate, causing an ethical dilemma for doctors. Because the primary duty of doctor is towards patient. The extent of family involvement varies from country to country. In contrast to Western individualistic cultures, most traditional Eastern cultures place more emphasis on the collective role of the family in decision making, including decisions on finances and the last part is legal, ethical, and social aspects of do not resuscitate DNR order. DNR is a legal order written in a hospital form or patient sheet conveying wishes of the patient not to receive cardiopulmonary resuscitation or advanced life care support. Do not intubate is another term for refusal in ICU. Such orders imply that patient wants to be allowed to have natural death. So the recent term is A&D. Terminally ill patients with A&D order should not be ignored and should be cared and comforted till last. There are strict protocols in countries that allow such orders. In India, a doctor may write DNR, but it has no validity in court of law. DNR often remains an oral communication between doctor and patient after consultation with family and healthcare team. This is an area that can cause many ifs and buts later on as it creates conflict among autonomy, beneficence, moral obligations of doctor and family. Now I will discuss social aspects of do not resuscitate. Socio-cultural, spiritual and religious differences have different views on death, dying and thus influence orders like do not resuscitate. Understanding this regional religious perspective on death and dying inculcates sensitivity, respect for belief and tradition, and empathy for the dying patient, and therefore doctors should understand it. In India, believers in the karmic principles consider euthanasia or the induced death as immoral and against doctrine of ahimsa. Suffering is considered as a part of the karma and spiritual value in Christianity and part of karma in Sikhism and Hinduism. Some elderly would like to die at home, then undergo painful procedures at hospital, knowing the futility of life. A dying patient expects that all the loved ones are around him at the time of death. Ideal time of death is considered when individual has completed his karmic, that is, fulfilled material gains, accomplished family, moral and social obligations. Thus he is ready to renounce earthly body and that is the time he wishes to die. This is an attainment of conscious or conscientious death to be reborn, and therefore these ethos and values are to be respected by the treating doctor. Two special forms of dying in India are Prayopavesha and Santhara, ending life in a gradually prescribed manner. Rituals of fasting unto death is a form of a new religious people accept instead of waiting for natural death. So these social aspects must be known and may be related to resuscitate or resuscitate. Ethical aspects of do not resuscitate. Two contradictory questions come in mind. Is allowing to die without medical care, that is hastening death, ethical? And second, should patients' suffering be increased by interventions, intubation, ACLS, prolongation of life on ventilation or machine? Now, from an ethical standpoint, DNR orders must therefore balance the degree of the trauma and pain due to treatment versus potential benefit. As a result, addressing end-of-life issues can be one of the major healthcare challenges for doctors and healthcare organizations. Physicians with the best intention and beneficence to the patient often struggle on these complex medical issues as there are no ready-made answers and each case is unique because of socio-cultural differences. Knowing such values and beliefs broadens perspective of doctor and helps him integrate these factors in making decisions in the best interest of. Why patients don't want CPR? This must be understood. Patient's perspective is there is no medical benefit expected. CPR is not meant for people who are terminally ill, and CPR is not likely to be successful for many patients. Quality of life would suffer. Sometimes CPR is only partly successful. Though the patient survives, they may suffer damage to the brain or other organs or permanently may be dependent on the machine to breathe. This can be particularly true for elderly and very frail, advancedly ill patients. Death is expected soon. Persons with terminal illness may not want aggressive interventions but prefer a natural, peaceful death. Therefore, many patients. Now let us come back to the case. She has expressed her wish not to intubate and not to depend on machine to live and insisted so again and again, but doctor has not documented it as advanced diuretic. Her son does not know such wish. Perhaps she has not divulged this information to him. Son was very distressed at his mother's health and that he wants everything possible to be done for her. Now the question to be addressed is how much importance should be assigned to patient wishes when son, the only family member, demanded actions contrary to. Now to intubate or not to intubate, one has to take decision taking few points here. Right to self-determination and autonomy, moral duty of doctor to respect patient wish. She was not incapable of making such decision at the time of making decision. Only 4% patients with chronic disease undergoing CPR for acute illness leave the hospital alive, and outcome is thus uncertain. Points in favor of intubation would be son is a legal heir and his wish is to give the best possible treatment, and he is also a surrogate decision maker, and there is no written advance directive that intubation should not be done, and there is always the backdrop of fear of the lawsuit, and therefore doctor should act in the best interest of patient. Beneficence is important. Not to intubate, autonomy is important. Now a decision can be made depending on the prevailing laws, the regulations and socio-cultural characteristics. And I would request every student and the participant of this discussion to access an insightful article that discusses and critically analysis of a similar case, and that has appeared in the American Family Physician 2003. Please access the article, go through and see how they have decided according to their prevailing regulations. You may also go through more references related to the discussion and this competence.